Welcome, everybody, to the Blueberry Pediatric podcast. Thank you so much for joining us. Today on the show, we have Mary Jane Beeson. Mary Jane Beeson is a visionary leader and strategic innovator in the healthcare sector with a sharp focus on government healthcare programs and Medicaid strategy. As the founder and president of Beeson Consulting Group, Mary Jane has spearheaded transformative growth initiatives, achieving a remarkable 50% year-over-year increase in Medicaid membership and securing pivotal contracts across 10 states. Her team's unparalleled success is reflected in an impressive 90% win rate on contracts, generating over $68 billion in revenue over just 4 years. With a deep commitment to advancing healthcare access and equity, Mary Jane has redefined business development in the healthcare space, implementing groundbreaking strategies that drive sustainable success. She's not only an exceptional leader, having managed a $14 million annual budget and built a high-performing team, but also a dedicated advocate for empowering organizations to transform the healthcare landscape. Welcome, Mary Jane. I'm so glad you're here with us.
Thanks so much, Lyndsey, and it's great to be here with Blueberry Pediatrics.
I'd love to hear a bit about your journey into healthcare. Clearly, you have vast experience, and just hear how that led you to where we are now.
Absolutely. So it doesn't seem like that long ago, but trust me, it was very long ago that I finished grad school and in Cleveland, Ohio, and I got hired by Case Western Reserve University's teaching hospitals. And when I first walked in, they said, by the way, the job is the Department of Pediatrics. Well, here I am. I'm single. I don't have any kids. I have a big Department of Pediatrics. And I would say there was an overwhelmingly large population of kids in our practice. We sat in a very diverse neighborhood with the majority of our members and their families speaking a second language. And that's where I really learned healthcare. I had two really great partners. I had a nurse on the outpatient side that also happened to be the president of the Pediatric Nurse Practitioner Association, so very progressive group. I had a pediatrician, Lolly McDavid, Yale trained, board certified pediatrician. And they really taught me a lot as a young new grad. They taught me about how members, they don't often have telephones. They don't often have transportation. If there's ever a copay for anything, they have to decide between, are they going to feed their child or are they going to pay the copay? So they often don't pick up the medications. And over the several years that I spent in that role, I really got to see the challenges of, people showing up for appointments on time because the transportation access that they did have that was covered by Medicaid didn't get them there on time. So at the end of the day, we often had 100 patients waiting to be seen that our pediatricians and our staff had to go home. So we would ship them all down to the emergency department and they would be seen. And then I decided I better ship my pediatricians down to the emergency department because in an emergency department, you have great physicians, but they're not really excited about screaming children. They just aren't. And they're also not always attuned to the unique needs of a child. And emergency departments, quite frankly, are scary. And so I really watched that happen. And I watched it take its toll on our pediatricians and on the families of the kids. You fast forward, I decide I'm going to go over to the university hospital. And I'm now over all of ambulatory and the pediatric emergency department. And I did that for about 2 years. I did a turnaround. And I watched a pediatrician one day, actually my chief of pediatrics, and he and I had a little bit of a disagreement because I had a parent who called me about him. And so I said, hey, doctor, did you really tell that mother that she didn't belong in the ER and to get over it? And he said, I actually did because they don't. And I said, yeah, but seriously, where else was she going to go? Her kid was screaming. The kid had an ear infection. There really was not anything else to do. And I said, I think you need to talk to her. And so I literally did a 3-way phone call with the pediatrician, with the parent, and with him just to recreate that bond. But he was frustrated because our emergency department was overflowing with kids just everywhere. So you fast forward, I moved to Atlanta. I'm the administrator of a children's hospital, really great children's hospital. And they had a service called, they had a nurse advice line service. And I'll just say that it was very valuable. But a lot of times a parent really wanted to talk to a physician about what do I do with my kid? And if they're making a choice in their head, this person said, I can probably stay home and go until tomorrow, that it's likely okay. but I really want to talk to my pediatrician. And again, access to care is a big deal. And pediatricians, they get burnout. They just leave or they decide not to take Medicaid. And that's what I'm really passionate about. You know, it really means a lot to me that people have access to care, and that's care wherever they want it to be. And that doesn't mean getting up at 3 o'clock in the morning if you don't have to and driving to an emergency department, because that's calling 911 is the only way you have to get there. So I did leave. I did leave the children's hospital environment, and I decided to go to work for the state of Georgia. And again, the state of Georgia, they are a major funder of Medicaid using your taxpayer dollars. So I don't know how many people know, but the dollars spent in a state for Medicaid, depending upon a lot of different factors, but generally the federal government picks up 80 to 90%, and the state budgets pick up 10 to 20%. Well, that's out of all of our pockets. And so don't you really want people to be getting the right care at the right place at the right time? Well, again, at the state of Georgia, we had just transitioned to Medicaid managed care. And it was a big deal because that meant we were going to make somebody else more responsible for something that we had little control over. And that was access to care. We had a big network, every pediatrician in the state, absolutely every family practitioner, everybody in the state takes Medicaid. They just do, but they often won't see the patient because they'll open up a few appointments a day. Medicaid is not a high paying payer,
right?
But they do pay, but just not a lot. And so you have to have a combination practice where you take insured as well as Medicaid. And oftentimes the Medicaid patients can't get in. And so it really meant, I eventually left the state after about almost 10 years, first as a consultant and as an employee. And I went to work for a big payer. And it was a job doing the age, blind, and disabled population in South Georgia. And I learned a lot. I would go on ride-alongs with my staff, and I would go to people's houses, and the nurses would go in and they would look in people's refrigerators, and there wouldn't be any food. And they talk to somebody and say, you've been to the emergency department 36 days in the last 2 months.
Wow.
Can you tell me why? You took an ambulance to the emergency department. I couldn't breathe, and I don't have air conditioning in my trailer, or my child has asthma, and we didn't have air conditioning. So if you go to the emergency department and spend the day there and then come home at night when it cools off, that's our best bet. So I learned a lot in that time period. I also learned as a payer, I single-handedly, as the CEO of that health plan, could go out and buy an air conditioner for their house. And guess what? I bought a lot of them. I called Home Depot. I said, deliver this afternoon, put it on my American Express card. They had an air conditioner in that house by that evening, and they never went back to the emergency department the rest of the summer. Same thing with asthmatics. Asthmatics kids often go to the emergency department. Parents get scared, the kids having a breathing attack. They have their inhaler, but they're still really nervous because to see your child really grasping is heartbreaking. And so I had this mother telling me this. And I said, well, did you call your pediatrician? Because, every time you do this, you go to the ER. It's not a great place for a kid because that in itself does have traumatic impact on children. It just does. You see everybody sicker than sick. And as a parent, it's really tough. Well, I'll just say it was really insightful to have parents tell me, we can't get transportation to pick us up. We call 911. That's why, all the whole host of things. So I would just say that riding along with my case managers and seeing, and then me as a payer, having that ability to change up things was to me, it was incredible. And then I will tell you what, I was telling them before you joined, Lyndsey, that I got pregnant the week of my 40th birthday. I'd been single 38 years of my life. I got married, found the love of my life. We got married. I got pregnant the week of my 40th birthday. I no longer worked at the children's hospital, but I did have that pediatrician's phone number that was the chief of staff of the hospital. And I called him. I said, Bob, I've got great news for you. And he said, what? He goes, you don't work at the hospital anymore. What's the good news? Are you coming back? And I said, no, I have selected you as my pediatrician. He was like, oh my God, Mary Jane, why did you do that? I said, well, I said, number one, I have your cell phone number. So that right there, I have 24/7 access to a pediatrician now. And number two, you're an advocate for children. And I having worked with many, many pediatricians over my career, there is no other advocate for a child like a pediatrician. I've also had tons of friends that are family practitioners. They're big advocates, but pediatricians, they are the heart of kids, whether it's a 3-week-old neonate that came home early from the hospital, low birth weight, or whether it's a 16-year-old kid that you noticed has depression and anxiety. And as a mom, you're getting worried because you hear about kids with depression and anxiety and you don't know where to go. So that's why I got Bob's phone number and I've got him on speed dial. And I did use him a number of times, as your staff will tell you later. But it's I do have a big passion, and I think I've said all I can say about my career journey. I'm thrilled to be talking with Blueberry Pediatrics today because the minute I heard about you guys, I was like so jazzed, like, oh my God, I wished I had them when I was pregnant. Bob wishes I had them too.
That's great.
Yeah.
That's hilarious. Well, I'm so glad you're here because you have so much experience on so many ends of things and also specific to pediatrics, which is hard to find. And for someone in your position and so knowledgeable and so passionate. I did leave out some of your roles, which are, and the names behind them in the intro, which was incredible within itself. But I'm going to add that you had leadership roles at Optum, Humana, United Healthcare. So you've really seen it all probably. So I would love to learn from that and have our audience learn from that as well. I'm going to go back through all of your roles and let me dive into the hospital. So the ER physician that you mentioned, and I think maybe in training I was guilty of, I don't know that I ever said that, but was thinking that all the time. Why are you here? You don't need to be here. And there's just such a lack of, I was in training, I was young, naive, such a lack of understanding of where the social aspects of medicine. But as pediatricians, there's also, I think a lot of us feel that we don't have so much power there, or there's only so much you could do. You see patients all day, and then what are you going to find out about which air conditioner can fit in their window? Like, it's very hard to do it all and to help them preventatively. And yet we do, I think pediatricians, it's like the crux of what we do. So with all of these issues, and especially where the kids are ending up in the emergency rooms, it's because they're not getting appointments with their doctors. There's no spots for Medicaid. And really, Medicaid reimbursement being low is a big crux of all this. So do you mind talking a little bit about that? Is there how do we change that?
I think a lot of physician groups are taking risk now, which means you get the total cost of care for the member on a monthly basis. And you as it's usually a large group with a large population of Medicaid patients that take risk. And it's your job to manage those dollars. So if you get several $100s a month, if they go into the emergency department every week or numerous times a week for asthma, your money's gone and suddenly you're in loss with that child that's got asthma, unless you have a solution to deal with it on an outpatient basis, whether that's telehealth or that's urgent care. And I would say the providers have gotten really innovative as partners to the payers about what they can do because they know they don't want the kids in the ER. We as a payer, as much as I've been a hospital administrator for many years and I have a family that works in healthcare that's on the hospital side, you don't want anybody exposed to an emergency department or a hospital in general that absolutely doesn't need to be there. And if you have a pediatrician access, if it's 2:00 in the morning and you can pick up the phone and call somebody and they can say to you, Mary Jane, we got this. Like, we haven't met before, but I'm a board certified pediatrician. Your pediatrician will get all of our notes of this phone call so we can have this connection. You can still follow up with your pediatrician. I mean, that makes all the difference when they know you're going to create that trifecta of a relationship with you, their child, the pediatrician. Like, that's the nirvana for a parent. And that's a parent on Medicaid or a parent on commercial insurance because parents are parents. Sometimes that parent is not a parent, but it's a caregiver. Sometimes it's grandma, sometimes it's an aunt. It's just really important that as a payer, and I've been on the payer side, I've been on the government side. The reason the government moved to managed care and it offers so much to a member to have access to those extra services that I just discussed, the telehealth, the air conditioner that I mentioned, the fact that any of these health plans can go out and purchase something. I looked at that lady's refrigerator one time and there was nothing in it. And all I could think was, what are they eating tonight?
Mm-hmm.
Like, that's really sad to me. So with social determinants of health, I looked at the case manager and said, let's call the local church, the local food bank. Let's find out if she's a woman of faith. Does she have a congregation? I mean, no one is going to let somebody in their community have an empty refrigerator, either for themselves or for their entire family. They just aren't. So, as having been a Medicaid administrator and executive, when we moved to Medicaid managed care, I felt like the weight had been lifted from my shoulders as a state employee. And then as I became that executive director of United Healthcare, managing the health plan in South Georgia, I told our case managers, and our case managers were nurses and social workers. I said, number one, get out and meet the providers, all the primary care physicians, go to their offices, find out what they need. We have a huge call center. We can call and make appointments for members to come in and get all of their primary care needs, get their immunizations done, and begin to create a relationship with their pediatrician. Because if somebody doesn't encourage them to do it, and you know what? And if their ride, their non-emergency transportation benefit doesn't come and pick them up, too bad. Call a taxi, put it on my credit card. I don't care. Do you know what I mean? I was so passionate about making sure that people got the right care at the right time at the right place. And, I wish that Blueberry Pediatrics had been there, because I will tell you, when I was running that program in South Georgia, 50% of our members in the age, blind, and disabled population were children.
Whoa. I did not expect that.
No, not at all. A significant amount of behavioral health need combined with medical need.
Right.
Both, and once you have a physical health and a behavioral health need, it really, access to care even tightens up more, because access to behavioral health is very, very limited in rural areas. And the majority of primary care physician can manage, I don't know, Lyndsey, what the percentage is. It's probably 98% of a behavioral health need can be met by a primary care physician. And if they need additional help, a primary care physician can get them linked directly into a psychiatrist, a psychologist, a licensed clinical social worker. And so I just think Blueberry Pediatrics has the ability to offer so much to people that have, particularly have challenges with rural access. I mean, that to me, that's a game changer for any health plan to say, we're going to need them. Because I'll tell you what, so I do business development. And what does that mean? Like, I go out and I help my company get new contracts. And so I usually go in and I talk to the Medicaid director at a state, their chief medical officer, the people over their women and children's program, the people over their hospital program. Depending upon how they're structured, you talk to a lot of different executives at a state, and you listen to what they say their pain points are. Number one, biggest pain point by far, emergency department utilization, because that is what drives up costs. And you get to the ER, and a pediatrician that you talk to and that understands the unique needs of your child. And that's the other thing too, is what I liked about Blueberry Pediatrics was you have such a diversity of staff that work for you, that it's probably likely that when somebody picks up my call, I'm going to get somebody like me. And I might get somebody that speaks Spanish, or I might get somebody that speaks Portuguese or some other language that really allows me to communicate more fully. Because in the world of health equity, people want to be cared for by people who look like them and who speak the same language. I mean, I've seen translation occur, and it's not very personal. And that's the other thing too, is every one of these members and their families, you have to be person-centered and family-centered, because everybody's going to have a unique need. Not everybody's going to fit in that little widget box that emergency departments have to put people in, because they only have so much time. So if you have somebody that can listen to your unique needs, that not only do you have this child that's got sickle cell, but you also have a baby that may have sickle cell. And you may also have two other people, neighbors' kids you're taking care of. And suddenly, this person's listening to you and they hear that you've got all this stuff going on. A pediatrician, regardless of where they are, doesn't really have that opportunity to listen to the whole life story of the whole family. And so that's why, when Lyndsey and I met, and I did a lot of research because it's really important to me that if I'm going to connect people and if I'm going to advocate about what I consider a great service, that I believe in it. And so I really do believe in it, having with the breadth of background that I've had and the type of businesses that I've been involved in, that I do see Blueberry Pediatrics as a game changer. If I were a state Medicaid director, and I've got friends that are state Medicators, I'd be calling all of them and saying, listen, all of you need to be talking to Blueberry Pediatrics. Quite
I
honestly,
appreciate that.
I've got some friends that have done that with a number of companies that they know that the service they offer is ultimately going to impact their state budget, to save their taxpayers money. And that's, when I worked for the state of Georgia, the doctors didn't get paid a lot, as, we talked about. And they get paid, they actually do much better when they get into value-based contracting arrangements where they can take full risk or where they can take partial risk. A health plan also likes to see that at the baseline, when you join, when you take our members, that this is the utilization of an emergency department. And suddenly those numbers go straight down because of a service like Blueberry Pediatrics. Like that is honestly, states love that.
Yeah.
And I've taught states how to score bids. That's the other thing too, is when I worked at a state, I said, look at the numbers. What's the value proposition of the innovation that they're talking about? Is it going to change anybody's life? Is it going to save our taxpayers money? Like, what is the value in this? And so I think more and more so, I would say in the last 5 to 7 years of my career, that right there is where states expect you to go. They expect you to help providers get through the risk model from value-based care. And when they really are ready, and you don't want anybody to take full risk that really doesn't have the capability of doing it, because you don't want to put somebody out of business. We need every single willing provider out there to see kids. Absolutely. And so that means, as a payer, if we have to shore up a provider and help them get to that next step, that's what these states hire us for, is to help the providers continue through that transition to eventually get to full risk if it's right for them to get there. And if it's not, let's get them upside risk, because you get upside risk and you get those ER visits down and you get those, the primary care visits up. That's what states wants to see. That's what they want to see.
Yeah, you do my job for me in explaining the value of pediatrics, of Blueberry Pediatrics, for sure. We know that about 50% of children across America really don't have great access to pediatricians. And a lot of that is because pediatricians either can't have clinics or maintain clinics and sustain them in rural areas where they're getting enough reimbursement for these Medicaid patients to really stay afloat. And it's very tough for them to, and those are the people, like you said, that are going to look like the community, talk like the community, and really provide the best, most effective care for the community. And unfortunately, they're not able to sustain that. So Blueberry does offer a service that meets the parents where they are, and they could do it from the comfort of their home and avoid these ER visits up to at least 40% costs that are incurred that are unnecessary, because kids don't need to be in the ER for things such as an ear infection, like you mentioned before. I'm curious if you've seen other types of innovations in your experience that is helping either value-based care or bringing down cost of care overall.
Yeah, so they're not so much in the pediatric space. I've seen telepsych actually pick up quite a bit. I've also seen some apps, digital apps, for BH and for loneliness. And I really wasn't like working for me. I'll be honest. I was like, I don't really get this. So I have a family member that during COVID, he was immunocompromised and was not allowed to leave his apartment for about 3 years because he had a transplant, and he had not been reimmunized from all of his childhood vaccines. So he really couldn't leave. And this woman that owned this loneliness company, she said, I'm going to give it to him for free. I was like, you don't have to do that. She goes, no, Mary Jane, I want to show you, because I know you like I know you're interested because I do. I like to see innovation and I like to see advancements in utilization of technology. So you fast forward, my nephew gets it, and he's about 2 years into COVID. And I said to him, "How is that? Do you like that?" He goes, "Oh, cool. It's so cool." I mean, like, seriously, I feel better. Like I like
Oh, great.
because I've been I honestly, you guys, I've been kind of depressed. Here I am up outside of Chicago. The weather stinks here. The sunshine doesn't come out most of the year, and I'm stuck in my apartment. And the nicest thing people did for me was they brought me a Christmas tree, and I couldn't decorate it. I think there was something about decorations. He said, but I could smell it. Like it was so nice that I had this tree. And he said, and they brought me food. And he goes, and then I had the solution. And when I got lonely, that's what I used to feel better. And I do feel better. And so I saw her at a conference recently and I said, okay, I'm no longer a naysayer. You're right. I was wrong. She said, told you. She told you. She said, you just got to try it once. And that, I
Mm-hmm.
said, well, and I think this was all when he was in his late 20s that he was using the service. And I
Mm-hmm.
think he still uses it today because he's never gone into remission. And so he still has some loneliness and depression issues. But he said, you can tell your friend, like, I'll be their person. It's
Uh,
good. So I like that.
yes, that's amazing. It's so great to have a solid mission like that for your company where you know you're changing people's lives and changing the direction and of the course of their lives. That's an awesome.
I also think that BH right now is, when you think of things that happened during COVID, particularly with kids,
Mm-hmm.
I mean, it is a little worrisome. I don't have future grandchildren yet. But if I did, it does worry me because I think it caused some anxiety and fear in children all over the world that suddenly we couldn't leave our house, suddenly we couldn't go to school. Um, I couldn't play with my friends, and it does worry me that we. I think we're still struggling with access to behavioral health. And as I said, I know that pediatricians and family practitioners, most primary care physicians, really have the ability to provide guidance and counseling and meet all the needs of a child or an adult. And then the worst, the ones that really do need more than that, providers have that connection. And I really appreciate that.
Yeah, absolutely. As healthcare systems are increasingly prioritizing value-based care, how do you see the shift impacting Medicaid programs and pediatric care specifically?
As I said earlier, you're going to have large, and I do know that they're already out there, large pediatric groups that are taking full risk.
Hmm.
And that means keeping kids out of the ER.
If there are large pediatric groups, you mean as part of hospitals or separate from hospital
Both,
systems? Okay.
both. Yeah. And, and bricks and mortar is one thing. Let's just be honest. You can't afford to put bricks and mortar everywhere. And even if you
Hmm.
could, the whole transportation issue is still a huge issue for state Medicaid agencies and for
Yeah.
payers. Really, for the most part, there's two companies, and in some states, one is great and the other's bad. In other states, it's vice versa. You're highly dependent upon the transportation network in the state. And in rural places, there is no network. There is no network. I tell you, I did some work in Wyoming for about 2 years, and me, I didn't want to drive because of the wind factor driving from Denver, Colorado to Cheyenne, Wyoming. Like I would see tractor trailer rigs laying on their side off of the
Oh my
highway just
goodness.
because of the high wind. So I would take a transportation service from the airport to Wyoming. And in the morning, I'd get up. I'm an East Coast girl, and they're not. And so I'd be up by like 3 o'clock in the morning, and I'd be like, "Oh gosh, I want to get into work now." Well, I called the front desk. I said, "Can you find a taxi for me?" The guy laughed. "We don't have taxis in this town, Mary Jane. Do you know where you are?" I said, "You're the capital of the state of Wyoming. Why can't I get transportation?" So when I think about that, the transportation I couldn't get, like how does a member get anywhere? Like
Right.
just so that that is that will always be a concern for access to care, and the fact that people have solutions where you and I can be on a camera and we can be talking. I tell you what, I talk to my doctor all the
Right.
time. I went to see her this morning, but I told her, Isabel, I love talking to you. You like on Zoom, like our telehealth calls are the happiest part of my day. Well, because I don't lose drive time. They have
Right.
me all primed for her. So I'm not wasting, there's no wasted time for the provider or for the patient. And I think that's where we all want to be, I the other thing too about pediatricians, they have these waiting rooms. They do have waiting rooms. And
Yes.
in a really good world, you've got the sick waiting room and then you have the well waiting room. And I've
Yeah.
seen both where they have nothing. It's just they have one big room because they don't have the ability to separate waiting rooms. But if I had a kid that was really sick, I really wouldn't want them in a waiting room with other
Right.
sick
It's the
kids.
same thing as like being in an ER when you don't really need to be. You're just going to catch more germs and get sick.
Yeah.
In fact, I was late for this call because I went to pick up my daughter from school. They told me she had pink eye. You know where we were yesterday? The pediatrician for a well check.
Oh yeah. Yep, there you go.
Right?
Yeah.
But yeah, I do agree with you about that. I'm very curious about your experience with the government side. It's a side that I know a lot less about. Do you think that there are I mean, definitely want to know about Medicaid reimbursement and like how we can pull levers there. But maybe is there other policy changes, or I'm not even sure where to aim this at. But I'm so curious as to what your exposure was there to know where we should be advocating.
States really are incentivizing health plans, and actually more than incentivizing, they actually have significant levers to damage payers that do not help providers move through the risk model. And when I say that, that means, it could be you reward the provider for closing some gaps in care. You reward the provider for a decrease in utilization of emergency department visits or increase of primary, you decrease emergency department visits, increase primary care visits. It's all of this. And then there are some groups, either hospital-based large pediatric groups with a large population of kids, or a freestanding large pediatric group with a large population of Medicaid kids. And the key is, if they're going to take full risk, you don't want them to take full risk unless they have a large enough population. So if they have a very high cost kid, that it doesn't really blow it for them. Because if you
Right.
take full risk, you could lose your practice in essence and all your funding. So
Yeah.
as a payer, they're putting the guys on the payer too to do an assessment. And if somebody would call me and say, "Hey, Mary Jane, I want to take full risk. I heard you guys pay so much more when you take full risk. I want more money." Well, the company is going to come in, the provider group's going to come in, and they're going to do a full risk assessment, and they're going to say, "You know what, you're doing good, but let's try to get you a little bit further advanced. Let's look at some reporting. Let's do a QBR with you and all of your staff and all of your pediatricians, and look at where you're doing well, where you're not doing so well, where there are opportunities for improvement, and where you might need our help. Like, is it technology support you need? Like, what is it that we can do?" Because as a payer, we can fund some of these fixes for providers.
Hmm.
And we often do because it's in our best interest. Because if we don't get you moved in that continuum in a way that makes the state client happy, they're going to come after us for liquidated damage. And they do.
Hmm.
I'll just say that they do. And, they're in the driver's seat right now. When they have a procurement coming up, that's when every company wants to come in and get that business. You mentioned early on that I brought a lot of new business to the company to the tune of like $60 billion. That's why these companies want to win this business, is because that 60 billion in itself, the revenue on that, the margin for a managed care company is really only 2 to 3%. But 2 to 3% of $60 billion is nothing to back off of. That's huge money. And
Hmm.
that's why these companies do things like I described: buy air conditioners, fill up refrigerators with food,
Right.
hire lots of case managers or LCSWs or MSWs, to go out and look in people's refrigerators and knock on their doors and look at things from a safety perspective. I think of case managers that have gone out, and, the state of Ohio is near and dear to my heart, doing lead checks, taking a flick of
Oh wow.
paint off of the, something in the, usually it's the window seal,
Mm-hmm.
taking it back, sending it in, lead, you know what I mean? And
Wow.
that's,
Yeah.
so that's why companies invest in staff and invest in technology and capabilities and invest in providers. Because the bottom line is the primary care provider is from a healthcare system perspective. It's not the hospital. Like every hospital administrator wants to think, hey, it's us. It's not them. It really is the primary care provider that is the orchestrator of everything that goes on with that member. And they should be.
Yeah.
They should be that single
Yeah.
point of contact. And they should be the one
Yes,
that
no
when mom
question.
has a problem, you know, she doesn't want, if she can't, she doesn't want to call that pediatrician at 3 o'clock in the morning. That poor person needs some sleep. But if they don't want to go to the ER, having access to a 24/7 pediatrician that will send a report back to that pediatrician and say, talk to mom last night. You should probably get him in this morning. Here's what I was hearing on the phone. We got him through the night. I checked the ear. It does look like something's going on. I put him on on an antibiotic, or there was nothing going on. The mom is screaming for, here's the other thing. Every mom wants an antibiotic, even when there's not an infection. Just
Oh,
give me one. They'll stop screaming if they take
all
one.
right.
You know what I mean?
Yeah.
Yeah, I've seen that
Yeah.
too. So, and you want to do the right thing for ultimately that kid and for their parents and for their family. And a primary care provider will do that.
Right. I think they also need to be empowered with the tools that like an MCO or pay, I guess the payer, yes, will be able to give them when it comes to social determinants of care or the programs that they're going to partner with so that they can provide them with the rides or provide them with the air conditioning example like that you gave or meals that they wouldn't don't if they don't have food security or the formula. So those wraparound services I think are huge, and I've seen in the field probably the same for you. That's just increasing now for accessibility to that, where we can hopefully create more preventive care, proactive care, and avoid these catastrophic ER visits that just
Yeah.
are not
Well,
necessary.
it's interesting. You meant earlier, you asked me about advances and innovations. One of
Hmm.
the things that's happened probably in the last 5 to 7 years is something called a closed loop referral system. And most companies are required by contract. They're required to have one, but I don't really know that they all use them. And some companies have gotten really innovative to work with the providers to leverage the use of a closed loop referral system. But part of it is making sure that the closed loop referral system has all of the community based organizations that can close a social determinant of health gap. So what does that mean? That means, and I actually used one when I had my health plan in 2005 in the state of Georgia, the AAAs, which is the Area Council on Aging, they had created one. And I said, can I buy it from you? I don't care what it costs. And my case managers were like, honestly, it was a Mary Jane Beeson love fest when I said I would buy it. They said, Mary Jane, you don't understand. Like, these are people that, they're in Hayhira, Georgia. We live in Atlanta, Mary Jane. A lot of us live in Atlanta. Like, we don't know where the closest food bank is. We don't know a lot of this stuff. But if we had this referral system, I can put in a street name and a zip code, and it tells me the closest place I can get dog food for this member's dog so that they will agree to go to their physician. This guy will not go to his physician unless I can find him dog food. I was like, you're kidding me. She said, no. She said, I'm really serious. And so, those types of systems now are out there. But our health plans have to get really smart. They have to work with these companies. They also have to work with each other because there are really only two companies in the industry. So if you get 4 or 5 health plans together in the state of Georgia or any state, I think Florida has probably like 9 or 10 health plans, and you load all of that community-based data into that system that you can all use, that means when that pediatrician is discharging this patient and the pediatrician looks at the nurse and says, do you think you can get this mom some diapers? Can you help them this? Can you do this? That the mom can, that the nurse can actually go into the closed loop referral system and tell the mom, this is where you can get these diapers. I'm going to give you the phone number. They're not going to charge you anything, and that's what you want. You want that mom to have trust in that pediatrician because that nurse just got her diapers, or that
Yeah,
front desk
that's
reception,
incredible. Right.
that nurse Dave just got us diapers. And it's the small things like that creates trust, particularly with moms and caregivers, that somebody got me something that I could not get myself. I could get they might figure I can get myself to a pediatrician or I can call a taxi, but where am I going to get these? Where am I going to get food? Where am I going to get diapers? Where am I going to get formula? And all of that's expensive. I don't know if any of you can go. I don't have grandchildren yet. I don't have kids. No, my kids are all grown, but I worry about my daughter affording formula. If she
Everything's expensive.
Yeah, it's very expensive. Very expensive.
Very. So for leaders aspiring to drive change in healthcare now, what skills or mindsets do you believe are the most critical?
I think always being very person-centered and family-centered is probably the most important thing any leader can do. I'm not a proponent of putting people in a box and having everybody fit in the same box, because that's not how people are. So I think it's really important to have that focus. I also think it's really important to meet people where they are. Where I am in my healthcare journey and my health literacy is drastically different than probably my neighbor next door. I'll just say that. And it's really important that we're cognizant of that, because not everybody should have to have a health literacy level that's off the scale to get the care that they need and to have a conversation with a physician or a nurse or a social worker. I also think that families want to be cared for people who look like them and speak their language. So I think as a leader in healthcare, we have to be very cognizant of that. When you think about you yourself, like, who do you want to be seen by? I want to be somebody that understands me. And I want them to, I don't want to have to speak through somebody else or a translator. And I've seen that. And I've seen staff that have had to do that. And it's really frustrating. It doesn't make you able to become the trusted partner with your patient, with their family, and oftentimes the most sensitive discussions or the toughest conversations you're ever going to. Who wants to do that through a translator?
Yes, it's very limiting.
I also want people to know, since I do have provider experience, being a doctor, a nurse, a social worker, working on the provider side is one of the toughest jobs in the world. And I don't care how much money anybody makes. When I think about the family events, I've seen my friends who are physicians and nurses give up. The holidays they've given up. I've also seen people go through training where they worked a 24-hour shift. They had a 24-hour shift off, and then they came back and did another one. And they did that not for a month or two. They did that for a year. And then it might get a little bit less the next year. And I'll just tell you, I have utmost respect for providers, and I've learned a lot from them. And hopefully they've learned a lot from me, because that's part of what I would tell providers. I want you to learn from me, and I want to learn from you. I don't want to do brain surgery, but I want to know what you need to do your job better. What are your roadblocks that I, as the administrator of this group or as the head of this hospital, what can I do to make your life better? And I think those are leadership qualities that anyone working in healthcare should walk in with, and know that you single-handedly have the ability to make a difference in somebody's life.
The neonatologist side of me thanks you deeply for that. I appreciate that.
Thank you.
Thank you all for tuning in to today's episode. Be sure to subscribe to the show for more episodes. And if you love the show, if you haven't already, please be sure to leave us a 5-star review.